Hey, CE Impact subscribers, welcome to the Game Changers Clinical Conversations podcast. I'm your host, Josh Kinsey, and as always, I'm excited about our conversation today. Dyslipidemia is a major contributor to cardiovascular disease, yet gaps in treatment and adherence remain common. In this episode, we'll review current guidelines, therapeutic updates, and how pharmacists can help patients achieve better lipid control and better long-term cardiovascular health. I am very, very excited to have a good friend and colleague with us today, Janelle Rusinger. Janelle, thank you. It's so good to see you.
My pleasure. I'm happy to be here.
So Janelle and I go back, been almost 5 years now, right? Or more.
Mm-hmm.
Yeah. So I had the great pleasure of getting to know Janelle when we lived in Kansas recently, and got to work with her for a few months, and just stayed friends and colleagues, and just super excited. As soon as this topic came up, I knew she was who I wanted to speak on this. This is her passion, her love. So again, thank you. I know it's busy time. I remember from academia, people always said, oh, it's the summer, it's easy peasy, and it's actually harder most of the time. So I know it's a busy time. So thanks for giving us your afternoon. So Janelle, for our listeners, since they're not as privileged as they don't know you that well, maybe. So go ahead and tell us a little bit about yourself and your practice side and all that good stuff.
Sure. So I am a clinical professor in the Department of Pharmacy Practice at the University of Kansas School of Pharmacy. I'm also currently the Associate Dean for Academic Affairs within the school. My practice site was the Atherosclerosis and Lipid Apheresis Center at the University of Kansas Medical Center. So I did that for over 20 years, focused on lipids, was able to have pharmacy residents in that clinic. There were 2 of us pharmacists in there, and then we worked under protocol with Dr. Patrick Moriarty, who was a physician and well-known in the lipid world. So I was very fortunate to be able to learn a lot from him in the 20 plus years of being there. Our clinic at the medical center, we kind of saw the worst of the worst. It was a referral clinic, so patients were sent to us if they couldn't tolerate a statin, or if they had multiple events on statins, or had familial hypercholesterolemia, or had high lipoprotein A, if they needed lipid apheresis, which is a really interesting, topic in itself. So learned a lot and had a great time in there. So.
That's great. And the clinic name is such a mouthful. Did y'all ever give it a quick little moniker that you could use, or did you always say that?
We always said that. We never ended up giving it an acronym or anything like that. A lot of times we would just be referred to as the Lipid Clinic.
Yeah, I was just going to say the clinic is probably what I would have done. So yeah, it's funny because, we pharmacists, people, we love our acronyms. So it's interesting that you never gave it a big acronym. So, well, again, thank you so much, Janelle. It's so good to see you, and thrilled to have you on our episode today. So without further ado, let's jump in. Let's get started on our topic for today. So again, our topic for today is dyslipidemia. And as always, I like to just kind of set the groundwork and make sure everybody's on the same page. So if you want to take just a minute or two to kind of remind us what dyslipidemia means, what it involves, and just kind of how its role, how it plays a role in cardiovascular risk and health.
Sure. So dyslipidemia is kind of a broad term that can encompass a lot of different types of changes or issues in cholesterol. So you can have mixed dyslipidemia, where you have high LDL and high triglycerides. You can have only high LDL. You may have low HDL. You may have familial hypercholesterolemia, which means you have very high levels of LDL because of a genetic mutation. And so kind of a broad term. And so one of the reasons why, a reason why that's a problem, is cardiovascular disease is still the number 1 cause of death in the United States. And a big contributor of that is the cholesterol, or the high cholesterol levels. So where that plaque formation then can lead to heart attack, to stroke, to needing a bypass, to stents, and a whole host of problems. And so addressing that, staying on top of it, being involved, educating our patients is really important. And hopefully we can knock that down from the leading cause one of these days. But it has been there for a long time.
For a long time, yeah, I know. You would think cancer would have eventually taken it over, but I think it's just, I mean, like you said, it's just such a juggernaut. So,
Mhm.
so remind us again, just, I always, like I said, like to just lay the foundation. Um, the big three that we think of are LDL, HDL, and triglycerides. And just to remind us again, LDL is considered the bad one. So we want that.
Mhm.
We don't want that to be high. HDL is the good one. And we want to be sure that we're
Mhm.
getting that as high as possible, right? And then our triglycerides are also another one of the bad ones that we want to try to keep on the lower end of things as well.
Yep.
And
Yeah.
everything can be affected by diet, but correct me if I'm wrong, triglycerides are more of one of those that are really affected by the diet, correct?
Yes,
Okay.
definitely.
Okay.
So a couple of things I always like to tell patients: LDL is the lousy cholesterol you want low.
Mm-hmm.
HDL is the helper cholesterol you want high, right? And then the triglycerides, you're right, are can largely be affected by diet and exercise. A few instances where, again, is a genetic component to it, but for the majority of the population, exercise and diet, weight loss can certainly bring those down.
Help out with those. Yep. Okay.
Mm-hmm.
And another one you mentioned, well, before we get into that, I'll segue. Well, no, let's segue into it now. So you mentioned lipoprotein A. So that's gotten a lot of press recently. So let's talk briefly about that really quick, and then we'll jump back to the other prevalence of dyslipidemia and everything. So while we're on
Sure.
that subject, let's talk about lipoprotein A real quick.
Okay. Well, I could talk about that probably the entire podcast alone. So you
Yeah.
can give me the signal that I need to wrap it up here pretty
Okay.
soon. Lipoprotein A has been a passion of Dr. Moriarty, so the physician I worked under in the 20 plus years that we worked with him. He has worked tirelessly to try to get it more attention, to get people to pay attention to it. It's another component of your cholesterol, but it's hereditary. So by the time you're about age 5, your level is stable.
Hmm.
And so it's not routinely checked. So when you do a lipid profile, it doesn't come along with the LDL, HDL, triglycerides. It's a separate test. But the problem is it is atherogenic in most instances. So very similar to LDL in that it can put you at increased risk for heart attacks, for strokes. It can put you at risk for valvular disease. And the problem with it is that you could literally eat twigs and berries and not change this level,
Hmm.
again, because of the genetic component.
Hmm.
And the other challenge is we don't really have any agents right now that can lower lipoprotein A. The PCSK9 inhibitors can maybe lower it about 25%. I mentioned that lipid apheresis. So in extreme cases, patients who use that, it will lower lipoprotein A significantly. But right now, we don't have anything to lower that. The good news is we've got a couple of agents that are in trials right
Okay.
now. And so the one agent can lower lipoprotein A by about 94%.
Wow.
And so we're very excited about that. Interestingly, the European lipid guidelines recommend that every person get that tested once.
Hmm.
The U.S. guidelines haven't quite got there yet. We recommend it more in patients that are high risk or have had multiple events, have had
Hmm.
family history, significant family history, and things like
Hmm.
that. So, but
Hmm.
I think you're going to be hearing a lot more about lipoprotein A in the near future.
Yeah, and I think, I mean, it makes sense that if and when those drugs come to fruition and they actually enter the market and get approved, I feel like then if there's something to treat it, hopefully it'll get the attention it needs by being tested because I mean, I'm not on that side of why test it. You're not going to be able to do anything with it. But I'm sure that's what people think is like, well, what's the point?
Mhm.
And if it's high or low, we can't do anything about it. So hopefully with the new medications in that class, that would be very
Mhm.
beneficial. Do you know, and I may be putting you on the spot, sorry. Do you know if those new medications also affect LDL? Like, do they do anything else or are they targeting solely lipoprotein A?
They're targeting solely
Okay.
lipoprotein A from
Okay.
what I'm understanding. And so, but the good news is they're looking for outcomes. They want, we have had agents in the past that lowered LDL levels, and things
Right.
like that, but didn't improve outcomes. And
Right.
so they're looking for some outcomes data for these. So it might be, hopefully in the next 5 years, maybe we'll
Mm.
see
Yeah.
uh, something
Hit the
come
market.
out for
Yeah, that'd
sure.
be
Yeah.
great. That'd be great.
Yeah.
Okay, well, thank you. That was just seem like a good segue when we were talking about the components. And I know that one has been in the news a lot lately because of these studies and just in general. So hopefully, Dr. Marathi he's finally getting his wish, and it's kind of,
Yes.
yeah, it's kind of coming more mainstream. So, let's back up just real briefly and just talk about the prevalence of dyslipidemia and its impact on public health in general, because I mean it can be a very costly disease if it obviously feeds into cardiovascular issues. And what's the importance of early detection? Like why?
Sure.
Yeah. So let's talk about that for a little bit.
Sure. So it looks like about 11% of adults that are age 20 or older have high cholesterol levels. And so early identification is important because the sooner you address it, hopefully you're putting off, any chance of an event down the road.
Mm-hmm.
Now, dyslipidemia is a little bit frustrating, right? Because it's a slow process and patients don't feel any different whether their cholesterol levels are high or whether they're low. And so it's very easy for people to put off getting that cholesterol checked, despite maybe a significant family history or maybe despite diabetes or, being overweight or anything like that. But we know that the earlier we can bring those cholesterol levels down and address those risk factors, the better off we are as far as preventing those events down the road. So,
right. Yeah. And that's a good point because, you think about someone who has diabetes, they usually, they feel different with low or high. It's easy to say like, oh, I need to get that under control because it makes me feel terrible or whatever. So it's an interesting point that because we don't feel a certain way with our levels of lipids, it's hard to say like, well, you'd feel better if you got it under control because it's not really the case. So you'd feel better mentally and emotionally, hopefully. But yeah, it's hard to kind of relay that to patients sometimes. Remind us about like if you find out that you have high levels and you're getting them under control, whether you go on medication or whether you lose weight or start exercising, whatever, can any of the damage that's been done, so like plaque buildup or whatever, can that be reversed? Are there benefits for that as well?
Sure. And so once, that plaque is laid down, what you want to do is stabilize it. So you want it to basically calcify, and it will do that over time if you bring down that cholesterol level. And so you may see a little bit of regression, but for it to completely go away is probably not the case. And once it's calcified, it's going to stay there. One thing that we would look at is a carotid IMT, kind of getting off subject here, but it's where we were looking at, it's a ultrasound where you look at non-calcified plaque. And we could actually, if we brought levels down, we could show regression in that non-calcified plaque. And so, yeah, you can. It may not, completely clean out the the arteries, but you're allowing it to stabilize, which then doesn't usually rupture, and then you're keeping it from getting larger.
Exactly. Just trying to think of more beneficial talking points to convince a patient, to do this or whatever. So yeah. Okay, that's great. So let's touch on really briefly. I'll just kind of mention some of the things that we're going to dig into deeper, but lots of opportunities for pharmacists. And I feel like I say that with every subject that we tackle on this podcast, but there's so many opportunities. So because we're so accessible and because we're knowledgeable and we have this training, but some of the things we're going to talk about and really dig into is medication optimization, lifestyle counseling, and that includes diet, exercise, supplements, things like that, and as well as just education in general about the disease, about the fact that it's a stepping stone to something bigger. It's not just, oh, okay, fine, I'll just have high LDL. No, that could lead to cardiovascular disease. That could lead to future complications, heart attack, et cetera, et cetera. So really just touching on the fact that education that we provide as pharmacists is also critical. So with that, let's jump into one of the first things, and that is helping with medication optimization, but that requires us to stay updated on the medications and the guidelines. So if you'll tell us a little bit about maybe how often the guidelines come out and why it's important to stay up to date on those and things like that.
Sure, sure. So the current guidelines are from 2018, the American Heart Association, American College of Cardiology, and the whole host of other groups that endorsed them, including the American Pharmacists Association. We are hoping that maybe another guideline will come out in the next few years. We're kind of due, I think, especially looking at some of the data that we're getting from maybe some of these newer drugs that might be coming out. I'm hopeful that something will be coming out before too long, but I don't think anything official has been actually announced. Yeah. I think kind of the maybe, I don't know, frustrating or overwhelming piece of it is when you look at the guidelines themselves, they're 40, 50 pages. And the average person is, I'm not going to read every word of the diabetes guidelines and the lipid guidelines and the hypertension guidelines. And so something that they implemented in the 2018 guidelines are the top 10 take-home messages.
I love that.
And so I think instead of maybe being overwhelmed by trying to look at that entire document, starting with simply those top 10 take-home messages and ensuring that you are, doing that and utilizing those to help guide your patients in some of the education.
Yeah. And, that fits well with what we kind of teach here is take away some nuggets. Like, we know that it's impossible to know every single thing about every single thing, but taking home some of those pearls and some of those little nuggets. So I love that they did that with that iteration. I think that's just smart, and hopefully others will continue to kind of take note of that, because again, it's kind of like the Cliff Notes version of it, so it's a good thing to kind of to also remind yourself of often, like to just look back at those and be reminded of things. So okay, so then along those same lines, another thing that we can do as pharmacists is guide therapy selection, dose optimization. So tell us a little bit about maybe some of the ways that can kind of come into play. Like, when do we change the dose of something, if the patient is not responding, or if they're having side effects, or, that kind of thing. So if you can talk a little bit about our role in that space, that'd be great.
Sure. And pharmacists, I think, have a really important role in that space. And so, if someone has not achieved that 50% reduction with their current statin, a reduction of LDL with their current statin, are they on the maximum dose? Do we need to bump that up a little bit? Do we need to switch them to a statin that's maybe a little bit more potent? Right, to be a little bit more aggressive with their therapy. Maybe they're already on the maximum dose of the current statin. Maybe we need to add ezetimibe, but the patient doesn't want to add another medication, and thinking about that. Or even if they're on ezetimibe and a statin, maybe it's time to have that conversation about the PCSK9 inhibitor.
Or maybe to have a conversation about adherence and make sure that they're actually taking their medication.
Exactly. Right. Or that there's not some side effect that's preventing them from taking it. And so I think there are a lot of pieces, a pharmacist doesn't even, I don't think, have to spend 30 minutes with the patient asking questions each time they come in, to maybe glean some of that information, can then guide some maybe a little bit longer conversations down the road.
Absolutely. Yeah. If there's one thing I'm learning with aging patients and aging parents and, learning that process with them, it's that, sometimes they like to just play with their meds. Like, today I don't need it because I feel great. And that's not really what should be happening. So again, when you're seeing that the numbers are not adding up, what are I love that you laid out like all the different scenarios. And then one of those also being, are you actually taking your med? And if not, why? And if there's a reason why, can we also fix that, So, that's great. What about, tell us what, obviously statins, and tell me, we said this in the beginning before we got on record, so I want you to repeat it because it's staggering. Tell us the number of patients who never fill their statin prescriptions.
So about 50% of patients do not fill their prescription for their statin, or they don't pick it up, right?
Yeah, right.
That's another
They
place.
never even drop it off or whatever. Yeah,
Right,
yeah.
right. And so now I think with electronic transmission of prescriptions, pharmacists again are at a great point
Mm,
to say, "Hey, Miss Jones, I
are you
have
supposed
this
to be
statin
taking
here
this?
for you. Yeah,
Yeah.
why are you not picking this one up? Let's have a conversation about that. What are your
Mm,
concerns? Where are you getting your information? Are
mm,
you, getting it from Google? Let's maybe look at some, point them in the direction of a few
yeah.
places they could get some good information, some
That's such a
reputable."
great point, Janelle. I love that because, I think I've been in that space. I know it's busy. The workflow is overwhelming, and you can't always take note of everything. But when you see something like that, don't just assume, oh, well, they must have talked with their doctor and decided not to take it, or oh, maybe that particular one went mail order for some reason, or whatever. Like, don't assume. I love that because you're so right. Like, have that moment, even if it's 2 minutes, to be like, hey, why did you never pick this up? Do you have concerns? And I love your question of where are you getting your information? Because that's such a good one. Because again, they're probably getting misinformation.
Mhm.
So yeah, that's such a great point. Remind us of what I was going for there. I wanted to share that because I think that's just such. I mean, that's just such a staggering number, the percentage of people who actually just don't ever follow through. So that in and of itself, if we get that under control, that can help a lot. But remind us what medications are currently out. Like what are some of the ones that we're going to see a lot of when we're treating dyslipidemia? What are
Sure.
the most common?
Sure. So still kind of the foundation, right, are the statins, that entire class there. Then we have the phenofibric or the fibric acid derivatives,
Mhm.
not used as much maybe because some of the data for some of the patients isn't as good, but
Okay.
you'll see that ezetimibe
Okay.
is another one I think you're going to see. You probably see a lot of bempedoic acid is another one that came out a couple years ago,
Hmm.
and probably seeing it to some extent. And then the PCSK9 inhibitors, those injectables are probably what you're going to be seeing as well.
Okay. And with the latter there, those are more reserved for severe cases, uncontrollable dyslipidemia. Is that kind of what we're looking at with those, with the case?
Sure.
Yeah.
Yeah. I think they also have a place for those who are statin intolerant. If you have someone who's high
Oh, sure.
risk, getting the myalgias from the statins, then you may see them as well. But the PCSK9 inhibitors can most certainly be used in combination with the statins, ezetimibe. And some insurance companies are kind of requiring that
That
step up,
therapy.
but you
Mhm.
can still keep them on
Okay.
those other agents.
Okay. Good to know. So we touched on this briefly. We talked about how we talked about adherence and personalized counseling and making sure that um, that they're getting the right information and that they know what to do with that information. MedSync, I think that's another thing that is important because that can help with adherence and that can make sure that they're picking it up along with their diabetes meds or whatever and just kind of keeping them on that cycle. But let's touch on briefly before we kind of get into some of the challenges that we face. Let's talk about how we can promote lifestyle interventions and what should we be talking about and promoting in that space to our patients.
Sure, sure. Diet and exercise are foundational, right? And every patient, regardless of whether it's genetic, whether, what the condition is, we should be promoting those lifestyle modifications. And, it kind of depends on the comfort level, how much pharmacists want to get into that. Certainly walking, we're not going to tell our 70-year-old patient to start jogging, right? So
Right.
simply walking, working up slowly, because the other thing we see is if they're put on a statin and start exercising, they don't know if it's the exercise or the medication that's causing their muscle aches, right? And
Mm-hmm.
so if they haven't
Right.
exercised before, they're going to have muscle aches. And so talking to them about that. The simple thing that we would say, we had a dietitian. We were fortunate to have a dietitian in our clinic, and she was absolutely
Mm.
fabulous. Everyone saw her. But the simple thing that we would say to patients is it's simply calories in, calories out.
Mm.
Dr. Moriarty would say if you would eat half of what you're eating right now, whether it's McDonald's every day, right? If you ate half of that, you're going to lose weight.
Right.
right?
Right.
And so simply just being mindful of what calories they're eating, and then if they can make those small changes, right?
Hmm.
Instead of getting the French fries with your hamburger, maybe get a side salad
Hmm.
or forego the fries altogether and eat some fruit, later on,
Oh,
or
mhm.
something like that.
Yep.
So you don't have to make a complete overhaul, but set some goals, make some small changes, and
Yeah.
um,
Yeah. That's
start
great.
that way.
What about smoking and alcohol intake? Do those come into play? I mean, obviously they come into play everywhere, but are they big factors in dyslipidemia control?
Absolutely. So, they say one drink a day, alcoholic drink a day is probably okay. But for someone with dyslipidemia, though it's again simply more calories that
Hmm.
they're drinking and not
Sure.
getting a lot of nutritional value from. So,
Mm.
being mindful of that. But specifically, if someone has high triglycerides, um, asking about how much they're drinking each day, and because alcohol can certainly contribute to that. And again, reducing the amount. If they say I must have wine every night with dinner, that we can work with that. Just let's make sure it's not half a bottle. Let's
Sure.
maybe do
Right.
one
Right.
one 4 ounce serving, or something like that. And then with the smoking, yeah, that the smoking, they need to stop.
Hmm.
There are some different resources, even if you don't have a smoking cessation program at your pharmacy. The some of the help lines and things like that. But the awesome thing too is that pharmacists can recommend some of the over the counter nicotine replacement.
Hmm.
And so
Yep.
certainly options there. But yeah, the smoking, that's a big
Yep.
one. That's
Yep. And I'll put a little shameless plug in here because every time that we have other education available to you, there is a smoking cessation course that we have that you can check out in your profile. And that can help you when you're talking with your patients and give guidance on recommendations and things like that too. So yeah, great call
Mhm.
out. Okay, let's jump into a little bit of the challenges that we may face as pharmacists in this space. So one of the things and we talked about this a little bit, and when we're looking at optimization of the medications and whatever, but polypharmacy in general, because let's face it, I don't know a percentage, but I'm sure the great number of percentage of our patients who have dyslipidemia also have something else. It's not usually
Mhm.
going to be the only thing they have, right? So they're probably going to have diabetes, or they're going to have something else that's in play that is going to also be causing a lot of medications to be prescribed and to have to be taken. So, what are some of the tips and tricks that you can share on that whole aspect of managing the polypharmacy and making sure that
Sure.
our dyslipidemia medication is not getting lost in the shuffle because of something
Yeah.
else? So, yeah.
Right. I think a really important thing is to empower the patients, and get them to have a current list of their medications that they carry with them all the time, including supplements, including
Mm.
vitamins. It was amazing in our clinic how many times patients would come in and just have no idea what they
They
were
were
on, and maybe they had been on a statin previously and we weren't sure if they were still on it, and then you add one, and so encouraging them to take charge of that, and always have a current list. I think another thing is ensuring that we are using medications when we can that work with the patient's lifestyle. So let's say a patient says, I cannot remember to take simvastatin at night. It's not going to happen. I don't remember to take any medications at night. Okay, we can work with that. Maybe we'll switch it to a torvastatin or rosuvastatin, have
Mhm.
longer half lives. You can take it in the morning, and maybe that will help with adherence.
Yeah.
You had mentioned the medication synchronization. That's huge that pharmacists can do. We would recommend pill boxes. I know people wouldn't always be on board with that, but as soon as they realize that it takes the guesswork, the thinking out of it, you could work with them that way as well.
Yeah.
And
Yeah. I
so
mean, I'm in my early 40s and I take no shame in having a pill box.
I love my pill box.
I know. I mean, I filled it up this morning, and just I love organization. I love to keep it on track, and I think that's always something that we can recommend our patients. It makes the most sense to me. So yeah.
Sure.
So we briefly touched on this as well, but obviously statin hesitancy, statin
Mhm.
misconceptions. There's a lot of unfortunately negative press that gets associated with statins, and for some reasons rightfully so, but in general they're great drugs, and
Hmm.
patients should be on them. Most patients should be on them if they're prescribed them. So any kind of things that you've learned over the years that kind of helps with that? I know just education in general, and like I love,
Hmm.
again, setting it up with where you're getting your information from. I love that.
Hmm.
That's gonna stick with me. But yeah, anything else in that space that can kind of help overcome that hesitancy or the reluctance
Sure.
for that. So
Sure. What we'd hear a lot of times is, my sister was on a statin and had problems, so I can't take it, or,
mm,
I'm not going to because my neighbor had problems and
yeah,
things like
yeah,
that. And so, interestingly, you see a lot of that, but there are different statins that patients can try. Some of the, again, atorvastatin, rosuvastatin are pretty clean, have longer half-lives, and so patients may do well with them. And if they don't, we always have options. We could try a different statin. We can try a lower dose. We could try alternative dosing.
hmm
Lots of data on once a week, twice a week, 3 times a week statins, especially
oh
with
wow,
those that have the longer half lives for certain.
yeah,
Like you had mentioned, making sure that if a patient is getting their information from Google or Reddit or wherever they get it from, having some sources that you can point them to.
hmm
There's a great site here on the American Heart Association, or here I just printed out a handout from
yeah,
the American Heart Association, or something like that. So having some options so that we're not telling them where you're going isn't good, but giving them some options to go get
yeah.
that information.
Redirecting as opposed to
Right.
getting onto them. Yeah, yeah.
Exactly.
hmm
Exactly. And then I think some persistence too. You're
Sure.
probably not going to convince them the first time.
No.
But what we would even do is say, just take it a couple times this week, see how you feel.
hmm
And then, we can maybe titrate up as we go. But that kind of helps them dip their toe in the water and get a
Sure.
little bit of confidence to
Yeah.
give it a go.
Great feedback. Great ideas and ways to kind of frame that conversation with the patient. So that's good. Well, I told you time's going to run out before we realize it. So we're already running out of time. But before we go, I want to be sure, is there anything else in this space, Chanel, that you're like, oh, I was just dying to tell everybody about this? Is there anything else that you want us to be sure we know about dyslipidemia or the therapies associated with it before we head out? And if not, then my final question to you is, what's the game changer here?
Sure.
What is the absolute take home point here? How can we really utilize the information that you've given us to make a difference? So,
Sure. Well, we'll jump to the game changer since
okay.
we're running out of time here. But I think for me, from my perspective, the game changer is that the pharmacists are the game changers
Mm,
in this space. And um, the patients, when those prescriptions come in and they're not picking them up,
mhm,
asking a few questions, being kind of persistent, finding out why, and being the source of that good information, that
mm,
reliable information. We mentioned earlier, staying up to date on that, and helping the patients be educated and helping them navigate this. I think sometimes they're scared,
mhm,
they're nervous, they're getting all kinds of information. So helping them navigate that
yeah,
and weed through all of it is important. So yeah, I think the pharmacists are the game changers
I love
uh,
that. I
in
love
this
that.
one.
And I think it's great. I think it's important that we also don't dismiss their concerns, and everything you've shared is setting it up in that same way. Like, don't dismiss it. They have valid concerns, and again, some of the evidence is true. They are rough on the body sometimes, but like you said, there are so many ways in which we can approach that therapy, and I think that is where you can shine as the pharmacist in being like, look. Yes, I know. I agree. They can, it can be difficult. You might have a side effect, but I know all about how to make this better for you, and you still get the outcome that you need. So, yeah. So I agree. Pharmacists are the game changer. I agree 100%. Well, Janelle, this was lovely. Thank you so much for your time today and for reminding us about all things dyslipidemia, and for giving us some great updates and great take home nuggets. I really appreciate your time.
Well, thank you. Thank you for having me. I really enjoyed it, and it was a privilege to be here today. Thank
Thank
you.
you. If you're a CE Plan subscriber, be sure to claim your CE credit for this episode of Game Changers by logging in at ceimpact.com. And as always, have a great week and keep learning. I can't wait to dig into another game-changing topic with you all again next time.